We have two thyroid surgeons on the Thyroid Center, Dr. Adzick and Dr. Kazahaya. Dr. Adzick is our surgeon-in-chief at CHOP, also runs the fetal program, started the fetal program and runs the fetal program, and is our primary surgeon for hyperinsulinism. So he's a surgeon with a great heart and great skills, and we're happy to have him on our team.
And thank you.
And great hands. So he'll talk a little bit about thyroid surgery for Graves' disease.
Thank you. So I'm going to go through the nuts and bolts of why an operation to treat a child with Graves' disease. Now, we have an educational DVD or video that perhaps some of you have seen, and if you're interested, I think there's some on the back table there that is referable to the Thyroid Center and Caring for Children with Thyroid Nodules, Thyroid Cancer, and particularly Graves' disease. And so my talk is going to be a series of video clips referable to surgical care from that DVD. And I thank Ashley Moore, who's here in the front with all the index cards with all the questions, for culling those video clips. And it should help explain the indications for an operation, measures taken to prevent complications of an operation, show what the goiters characteristic of Graves' disease actually look like, discuss patient care in the days after an operation and follow-up, show our team, so it gives me a chance to brag about our team, and discuss research for the future. So the motif in these video clips is a butterfly, because a butterfly is like the thyroid gland, right? With the two wings or the lobes, and the body of the butterfly is the isthmus. So let's start.
Thyroid surgery in children doesn't occur very commonly, so you need to go to a place that has a thyroid surgeon that does this frequently. We define that as a surgeon who is performing thyroid surgeries in children and adolescents at least 30 times a year.
We decided best to go with someone who was very specific in performing that type of surgery, and really, if we were going to do that, we had to come here at CHOP.
I was really scared at first, but then when I met Dr. Adzick and he sat me down and talked about everything, I felt more comfortable knowing that mine was going to be in his hands. And it was all basically the doctors themselves, meeting them helped a lot.
So this shows the indications for an operation for Graves' disease and which patients are good surgical candidates. Well, as Dr. Barr reviewed, those who have failed medical therapy or have significant side effects from medical therapy. He reviewed for those patients with Graves' disease who have a thyroid nodule as defined by thyroid ultrasound, may have a suspicious or confirmed cancer, and reviewed those 32 surgically treated patients here at CHOP, 7 of whom had cancer. A massive goiter, particularly if it causes compressive symptoms of the airway or compromise of swallowing or pain. Dr. Katowitz, who's one of the best oculoplastic surgeons in the world, is going to talk about eye signs and symptoms and surgical approaches, failure of radioiodine therapy, and patient family preference, desire for immediate relief of symptomatology, eliminate the recurrence risk. There's some age factors, and then a fear of radiation exposure.
There are many different approaches to patients with thyroid disease who need surgery. For instance, there are those patients with Graves' disease, with large goiters, who for whatever reason need an operation, usually because they can't be controlled well medically, and those children require a total thyroidectomy.
So we remove 98% of the thyroid gland, 99% of the thyroid gland, with the hopes that we make the patient hypothyroid. We want to remove as much of the thyroid gland as safely possible so that they need to be put on thyroid hormone replacement.
Hi, good morning. I'm Ari Weintraub from Anesthesia. How are you?
The anesthesiology team is very crucial before surgery as well as during surgery, calming the patient's fears, explaining everything so that they really understand what's going on, as well as providing the appropriate anesthesia during the surgical procedure.
Once the patient is anesthetized, the patient is positioned at an angle as far as your torso goes, and your head is back and your neck is extended. And the wound that's made for the operation is a sideways wound because that allows good exposure of the thyroid gland, and it also follows the skin lines in the neck to give the most cosmetically appealing healing process. And then there are strap muscles in front of the thyroid gland, and we push those muscles aside to expose the butterfly. In the course of doing the operation and removing either one side of the butterfly or the entire butterfly, it's important that I find and protect certain structures. First of all, two nerves. They're called the recurrent laryngeal nerves. There's one on each side. They run right in the groove between the windpipe, which is called the trachea, and the esophagus, which is the food tube behind. And those nerves come up from the chest and they run up to where the vocal cords are in the voice box, which is just above the thyroid gland. And those nerves are about the size, depending on the age of the patient, of an angel hair pasta strand. And they're very delicate, and frequently will abut the thyroid gland, so we need to peel the thyroid gland off of those nerves, one or both sides.
Those nerves are nerves that actually control the voice box, and so if you have damage on both sides, then a patient will have significant breathing problems to a point that they would need a tracheostomy. Or if the damage is not to both sides or a problem with the nerve, sometimes it can be permanent enough where it causes hoarseness.
That occurs very infrequently, but when it does occur, it's a very debilitating process, and it's something, again, that should increase someone's concern of who they're sending the patient to as far as surgery, because that really needs to be avoided in the best interest of long-term care for that patient.
The second important structures are parathyroid glands, and they are usually 4 in number. 2 are on the top, 2 are at the bottom. There can be anatomic variability as far as where they are. They frequently share blood supply with the thyroid gland, and they sometimes need to be peeled off the thyroid gland. For surgeons who operate on children with thyroid disease, it's important to have a sort of hand-in-glove relationship with the pediatric pathologist.
Sometimes we will receive parathyroid glands or tissue that is suspicious for being parathyroid, and we can do an intraoperative consultation, a frozen section, to determine whether or not that's actually what they are, or whether they're thyroid or lymph nodes or connective tissue.
Once we're finished with the thyroid portion of the operation, those muscles in the front are put back together, and then it's very important to close the wound in layers using absorbable sutures that will dissolve once the child is healed. So really the only thing that's on the wound are little steri strips running sideways along the wound. And thyroid wounds, for the most part, heal beautifully. Initially, they may be a little red and a little raised and a little firm, but that's normal because that's the healing ridge that occurs with any wound. Long term, in 6 to 9 months, it would be a very unusual circumstance in which there wasn't a very soft, flat, fine scar that might be barely noticeable.
So this shows a list of ways to mitigate or prevent complications of an operation. The first risk for a child with Graves' disease is the risk of thyroid storm. During the operation, with manipulation of the large thyroid gland, there can be a massive release of thyroid hormone, which can cause high blood pressure, very high heart rate, for the postoperative patient, agitation, delirium, congestive heart failure. So how do we prevent that? Well, one of the things that Dr. Bauer pointed out is that it's important to use anti-thyroid drugs if possible preoperatively to bring the free T3 and T4 into the normal range. Beta blockers, which bring down the heart rate for that sort of hyperthyroidism symptoms. And then to give an iodide product. It's called SSKI, which stands for saturated solution of potassium iodide, or Lugol's solution is another sort of product, which is given daily for 7 to 10 days before the operation to basically shut down the thyroid hormone producing factory. And it also makes my life more straightforward by reducing thyroid blood flow and vascularity. So that's very important that the patient be euthyroid before we do the operation. The recurrent laryngeal nerves you saw, there's those two little nerves here on the side that run behind the thyroid gland. We on a routine basis, use nerve monitoring with a special endotracheal tube that has a sensor right close to the vocal cord so that we can have an auditory response when I use a probe and touch that nerve. So we're quite good at that and preserving recurrent laryngeal nerve function. And then there's the issue of hypoparathyroidism. You saw the parathyroid glands, which are these little tiny kidney bean shaped glands, usually 4. And they share the same blood supply with the thyroid, and I oftentimes need to peel them off the thyroid gland, and they can be stunned for a while. So there's a state of hypoparathyroidism during the post-operative time period until those glands start to work again. Those parathyroid glands make parathyroid hormone, which regulates the calcium in the blood. So if those parathyroid hormone levels are decreased, the patient's blood calcium goes down. So the way we mitigate that risk is, first of all, we have a way to measure in the operating room before and then 10 and 30 minutes after resection of the thyroid gland parathyroid hormone levels to see how much the parathyroid glands are affected. And that allows us to craft how much oral calcium the patient should get during the postoperative period until the parathyroid glands get better. You saw the slides with the pathologist. If there's a question about the viability of a parathyroid gland in the operating room, I take a little tiny slice. We send that for a frozen section. Once it's confirmed to be the parathyroid gland, I can then mince that parathyroid gland up and then implant it into the sternocleidomastoid muscle here that helps you turn your head. And then in about 6 weeks, it'll develop a new blood supply, and those parathyroid gland cells are preserved, and that will function. So that's called a parathyroid autotransplant. We also check before the operation to make sure that the child's vitamin D levels are in the normal range, because if they're low, the risk of low calcium in the blood after the operation is higher. And then, of course, we check post-operative calcium levels every 6 hours for the first day or so after the operation. And I always tell the family to think in terms of a 2-night hospital stay. It may only be a 1-night hospital stay, but it's all about calcium regulation. Experience counts with this sort of work, as Dr. Bauer emphasized. Of those 32 cases of total thyroidectomy for Graves' disease, we have had none of the complications shown on the slide. Now, what do these goiters look like? So I'm going to show you a collage of goiters for Graves' disease after thyroidectomy from 6 patients. And you can see that they're huge, these glands. This is a ruler on each slide that's 6 inches in length, and you can see that these are very large butterflies of different sort of shape, right lobe, left lobe, the isthmus, and then in some cases there's a so-called pyramidal lobe, and that's important to remove that, because if you don't, then that can regrow and the patient can get recurrent symptoms. Let's learn about what it's like in the days after the operation.
When a patient undergoes thyroid surgery, the recovery part of that is actually pretty quick. Maybe 2 or 3 days in the hospital.
They're monitored postoperatively to make certain that rare complications don't occur, such as bleeding or infection. We want to make certain that their pain management is good and that they can eat and drink.
We're watching to ensure that the calcium does not decrease, because the parathyroid glands are attached to the back of the thyroid. Those are the endocrine glands in our body that make parathyroid hormone, which is the hormone that controls calcium metabolism. And when the thyroid is removed, there can be a transient period of time where the parathyroid glands don't work as well, and we have to give calcium supplementation and vitamin D supplementation, or it could be a permanent thing. So depending on the extent of the surgery depends on the risk for calcium issues, and that will also help determine how long the family and the patient will have to stay in the hospital.
Now, what about a follow-up after the operation or after radioiodine ablation?
The follow-up that occurs after surgical removal of a thyroid gland for Graves' disease is actually a little less complicated than giving radioactive iodine. They can go on thyroid hormone replacement sooner. Thyroid hormone, compared to the medicines we use to treat Graves', is a much simpler prescribing schedule. It's a once-a-day medicine. It's a very stable medicine. and we may only need to follow thyroid functions every 3 to 6 months, and eventually maybe even only 1 or 2 times a year, depending on the age of the patient. For a Graves' disease patient that's undergone ablation, usually it takes about 4 to 6 months after giving radioactive iodine to see that you've given enough of it to get rid of the thyroid gland. So the follow-up during that 3 to 6 months after giving radioactive iodine to a Graves' disease patient may be more frequent than every 3 months. It might be labs every couple weeks, or at least labs every month, to try to follow how effective that treatment dose was.
And of course, this sort of work to take care of Graves' disease patients requires a team. And that's the team that we have at the Thyroid Center at the Children's Hospital of Philadelphia, and in my view is world class. Now, Dr. Bauer won't brag about himself, but I'll brag about him. He's the premier pediatric thyroidologist in the galaxy. And so we've built this program around him. And this is of interest to me because I like to be involved in multidisciplinary things, our Center for Fetal Diagnosis and Treatment, for instance, or our Congenital Hyperinsulinism Center, for instance. And I think the future is really for that sort of multidisciplinary work. And it attracts patients locally, regionally, nationally, internationally. And it's very important to have the highest level of care that can be provided by that sort of team, that sort of expertise. As Dr. Bauer mentioned, Dr. Kazahaya and I are the ones who do the thyroidectomies here at CHOP. This coming year, I think between the two of us, we'll do close to 100 thyroidectomies for thyroid nodules, thyroid cancer, and for Graves' disease. And that just continues to grow and grow and grow, and it's an honor and a privilege to be part of that. So let's take a look at our team so that the video can brag about them.
The expertise that's available here in the Pediatric Thyroid Center at CHOP is multiple layers, which I think lead to special care and special results.
We all work very closely together
to make sure that we really come together as a team and give the best care that the patient really requires.
So we can let her go back on her diet and put her back on her Synthroid. It'll be easy, but it's reachable.
It's reachable. The disciplines include surgery, the surgeons who actually remove the tissue.
We have endocrinologists who are world famous in what they do in terms of the all endocrine glands. Coupled with that, we have a very good collaboration between endocrine and oncology.
Radiology.
Every single operation is done with a pediatric anesthesiologist.
And the pathology as well.
Nursing is a very important component between disciplines.
It's kind of the single point of contact.
In terms of getting all the information needed to have the patient evaluated in the thyroid center.
And providing the patient with the education and the care coordination to facilitate the more difficult medical system.
We have patients who are referred locally, regionally, nationally, and even internationally who want that sort of expertise for their children. But coming from such a distance leads to special needs for lodging and advice and financial support in some cases.
We're fortunate in the center to have a social worker involved in the care of these patients, which is very important so the patient is not only cared for in terms of what they need medically, but also what they need emotionally.
For a child going through this process, we have access to child life support. The child life specialists provide expertise in many of the psychological aspects of going through an operation that a child and a family really need.
One of the advantages of where Children's Hospital Philadelphia is located is that we're adjacent to the Hospital of University of Pennsylvania.
We work in partnership with them and can cull all their expertise, whether it be in pathology or other aspects of care that we can now apply to children.
And when the children are old enough, they're young adults, because we see kids up to age 23, which aren't really kids, they're young adults. But the transition of care then is easily set in place.
It's very important for the patient and their family to be very involved during the entire process.
The team was all really helpful in explaining it, like getting us through it, because we never experienced any of this before.
It would have been a lot more difficult to get through this if we didn't have that thyroid center supporting us.
They really need to understand the process, and we encourage them to write down questions, to bring them in, and we go through them. We've gone through lists sometimes as long as 15 to 20 questions long, and that's what we want. We want them to read. We want them to be informed.
I did feel like it was part of a team effort because it started off with Dr. Bauer diagnosing me, but then he gave me the options, and all the doctors were willing to work with me no matter what route I took.
The family and the patient provide a very important part of that team for us because they know their child best. The child knows themselves best.
From the beginning to the end, when you have your first appointment, all the way through the surgery, they seem to be, very much all in communication and willing to communicate with you and back with your concerns.
Even though there's a certain way to treat a disease, the patient is not a disease, the patient is a patient.
When we look in the microscope, it's not just looking at a piece of tissue, it's really bearing in mind that this is something that comes from an individual, it comes from a child, it comes from a child with a family.
The families inspire me and humble me and educate me and remind me that we don't have all the answers, but finding them is important.
So what now, what next? Well, our team strives to cure, to educate, and to discover. So let's learn about learning for the future.
The future for these patients is very bright. They already have a very good prognostic rate.
One of the most important parts that the center can provide is a strong research component.
We want to improve lifelong health of the child, not just cure disease, in 10 or 15 years, but what's going to happen to them over their lifetime. And research is really the key entry point to figuring that out.
Research is really now focused upon the genetic underpinnings of disease.
That sort of rigorous approach where we're trying to understand the sort of secrets of thyroid disease is very important.
These types of endeavors can only happen in a big institution like the Children's Hospital of Philadelphia, where it's recognized not only for the kind of clinical care we give, but also at the same time leaders in the field with respect to different various research disciplines.
It's one thing to identify that there's a need, and then there's another to try to do something about it.
And you have to have all the links with the research piece and the education piece and all these smart folks focusing on this problem to help push the boulder up the hill to enhance our understanding of thyroid disease in children.